do ask to try and I can get it for her. And she...
So, welcome everyone. We're doing Path Potpourri this morning for those joining us remotely. And everybody got their eyeballs in? Okay. Morning. David, what do you see and what's your differential?
I think probably the punch biopsy. See, there's a compact stratocorneum. There's something going on in the epidermis. There's kind of, some evacuated cells, maybe some RBC extravasation, perhaps.
So let's go back to the corneum real quick. You said compact. Is it compact like pathologically compact or compact basket weave like dorsum of hand or foot compact?
The latter. So just orthohyperkeratosis or ortho.
Yeah.
Orthosis,
So probably normal for anatomic site, but suggests maybe acral. Acral but not volar.
Yeah.
Because it retains its basket weave, but it's a little dense. Okay, and then all of these guys?
So probably erythrocytes, or could be apoptotic keratinocytes.
Yeah, exactly. Some are still nucleated.
Yeah.
So if that's all apoptotic keratinocytes,
then we're talking more about there's a little bit of interface and vacuolization, so maybe more of like an erythema multiforme.
exactly. That's exactly right. Well done. So it anatomic site is a clue. Most common place for EM is dorsum of hand or foot. Even though pictures and textbooks often show palm, it should show this because dorsum of hand or foot's the more common. That corneum is typical acute corneum, dorsum hand or foot. Lots of dead reds plus vacuolar interface. Death out of proportion to lymphs puts you in an EM-TEN type spectrum. This was actually a patient who went on to full-blown toxic epidermal necrolysis, but histologically you can't tell them apart. So the same. Other things that would be in the differential. Acute phototoxic reaction. Phototoxic reaction to doxycycline doesn't look that dissimilar. You have dead red, so-called sunburn cells, and vacuolar interface. So acute phototoxic reaction looks very similar. Stills can have the multiple dyskeratotic cells, but stills lacks the interface dermatitis. May or may not have a dermal neutrophilic infiltrate. So stills can have the dead reds, doesn't have the interface. Incontinentia pigmenti, you'd expect the collagen to be finer and brighter red because it would probably be kid skin. In the verrucous phase, you can have all the dead reds, but again, you don't have the vacuolar interface, and you may or may not have eosinophils still present. Okay.
We were wondering in this peanut gallery of GVHD.
GVH. So GVH definitely belongs in that differential. Things that might be a little different for GVH. A little more background epithelial disorder and atypia. Here, when you look at the nuclei, they're really pretty bland and uniform. A little more atypia maybe as chemo effect in the background of GVH. The other thing is GVH, very acute, could have a corneum like this, but most GVH we see as subacute, and so there's some alteration in the corneum.
So more atypical and more alteration.
More atypical, but you're absolutely right. That's another thing that should have been discussed in the differential. My omission.
Yeah.
Okay. Okay. James, do this the easy way. And you can interpret what that might be.
I have no idea.
Okay.
Oh, you're talking about... Is that a corner in the middle? No.
Oh, no, not corner.
Okay.
But if you looked at the lymphs, what's their orientation?
North and south, I would say.
Yeah. Related to what's in the center there?
A follicle.
So vertical column of lymphs related to a follicle is usually,
Lupus.
yep, you got it. Now you start looking for other things. Patchy lymphoid, vacuolar interface. Do you see any mucin out in the dermis?
A lot of sun damage, but probably some of that crap is.
Yeah, probably some of that crap is. And there is certainly space between the collagen bundles. But just what I meant by the easy way is if you have vertical columns of lymphs in the dermis, not a whole lot does that. So, lupus is your most likely. So then you start looking for other features. So vertical column of lymph following hair follicle, probably lupus. And then, later you might look for other things if there are no other features of lupus, but that would be the low-hanging fruit.
So it looks like it almost looked like a DF in a way with the collagen trapping, but I think it's more like a sort of granulomatous infiltrate, or at least interstitial.
So certainly an interstitial busy dermis, so things you would think of include granuloma annulare, DF, things like that. Looking at this one, is it top to bottom, side to side, or is it focal and patchy?
It's focal and patchy.
And do you have any areas where the collagen has degenerated in their space between collagen bundles?
Yes.
And that probably represents,
GA.
yeah, mucin, so GA. So you correctly said, probably granulomatous, but certainly interstitial. You can always get a stain if there's a question. In this case, NLD is top to bottom, side to side. GA is focal and patchy. GA has degeneration of collagen with replacement by mucin, and you can see the space between the collagen bundles. Well done.
HPAP.
So certainly looks like an apocrine maze, and this one is an HPAP. What if I told you this pretty much identical looking lesion came from a nipple?
SPAP? Or no,
Erosive adenomatosis intraductal papilloma is basically like an HPAP within the mammary duct in the nipple. So similar lesion, there's a similar lesion to an HPAP that occurs in salivary gland. There's a similar one that occurs in the ear, external ear cerumen. Pretty much anywhere where you have apocrine glands, you can get something like that. The one that's probably the scariest, I will ask the fellows, what if you had something that looked a whole lot like an HPAP or an apocrine cystadenoma, but you're on the eyelid? What are you worried about?
Endocrine mucin producing.
Yeah, endocrine mucin producing sweat gland carcinoma. So there you may want to get synaptophysin, some kind of neuroendocrine markers, because they start as hydrocystomas. Along the way, they look a whole lot like cystadenoma or HPAP, but they end their life as straight out mucinous carcinoma. So pay a little attention to site in terms of what that histology might mean.
This one almost looks like, can't quite tell if that's like gout or early.
Yeah, there's certainly something deposited there, right? So we can look a little bit higher,
Even,
looking at the pattern of the crystals.
feathery.
Yeah, I mean, that's pretty feathery, so that's good for gout.
Great spot.
Okay, Ing.
Nice me to describe. And in the first impression, I can see some hemosiderin and some red cells. There are some enlarged vessels and
Very good. In the pattern of the vessels, they're sort of in big round balls. So lots of erythrocyte extravasation, lots of hemosiderin, just as you said. It's a chronic condition, as evidenced by the compact corneum and the acanthosis. And then you have nodular, cannonball-like angioplasia of blood vessels.
it's amyloid or other things deposit in the superficial dermis.
Oh, so you're thinking of possibility of amyloid deposition. There, the pigment would normally be melanin. So anyone else want to jump in with this description? Stasis. So stasis dermatitis. You were absolutely right, spot on with your description. Pigment, brown pigment in skin can only be one of three things, either clinically or histologically. It's got to be hemosiderin, melanin, or lipofuscin. In this case, you correctly saw the red cell extravasation, and so characterized it as hemosiderin. It's a chronic condition, chronic corneum, epidermal hyperplasia, and then nodular angioplasia puts you on the shin, and stasis dermatitis.
Looks like we have a nodule. There's like a mix of larger blue cell and then like a gray cell.
Yeah, so there are
It's like a
paler
spiral.
blue cells and grayer blue cells, and it's speckled with jet black lymphocytes, and it has duct differentiation, and you correctly said it is a spiroadenoma. Very good. And this is one that is a little tougher than most, right? It doesn't hit you as a big blue ball right at scan, and yet you recognize the features, you talked your way through it. This is exactly the kind of spiroadenoma that would probably perform well in an exam setting, because it's not, one looker the first year knows it's a spiroadenoma. You got to think your way through it, but it's a spiroadenoma. So a little bit less common appearance of common things that are uncommon but non-controversial. Those are always, good things to know.
We have kind of interface pattern.
So you correctly identified as interface. And now the next question for interface, is it lots of holes out of proportion to lymphs, or is it closer to a lymph in every hole?
I think it's closer to a lymph in every hole.
So what's your differential for a lymph in every hole interface?
I know CTCL is like a different.
So MF, and then
It's like, is it LYP?
not LYP, you're in the right ballpark. You're thinking the right thing, you just said the wrong words. LYP has malignant cells but looks a lot like pleva, psoriasis lichenoides. You were thinking the right thing. And then what else can look like that?
I'm not sure off the top of my head.
Anyone else? Lymph in every hole, early evolving stage of BLK. Fixed drug can do it, but it's usually polymorphous. Syphilis can do it too, right? This one has a lot of erythrocyte extravasation. That tends to go with which one?
Pleva?
Yeah, so it tends to go with pityriasis lichenoides. For MF, you might expect more papillodermal fibrosis, which is very characteristic. A lymph in every hole plus papillodermal fibrosis, you think MF. lymph in every hole plus red cell extravasation, you think pityriasis lichenoides. There are neutrophils in the horn. Neutrophilic scale crust is great for pleva, sort of a dirty horn neutrophilic scale crust, but also brings back the possibility of syphilis, as does the interstitial busy dermis. So I'd say this is absolutely pleva unless it's syphilis, and you might want to check for that. History was pleva.
Pretty well circumscribed nodule. Looks like a lot of histiocytes, sort of epithelial-looking histiocytes, and maybe fibrin.
And so the question, more fibrin or more ropey collagen?
I'm guessing that would be collagen.
I do, in fact.
Mm-hmm.
This one, it's picking up an unusual amount of stain, but it definitely has a ropey look, which fibrin wouldn't have. So if it's collagen, and these things, so this is a lump of cells producing collagen, and they're all uniform and gray, kind of epithelioid.
I mean, epithelial histiocytoma.
So epithelioid histiocytoma is one, tends to be kind of superficial. Other thing with
It could be a giant cell tumor.
yeah, giant cell tumor, and if those giant cell tumor osteoclast cells were absent, then the rest of it is exactly what fibroma of tendon sheath looks like. Those uniform gray plump fibrocytes and the ropey collagen. Very good. Something that is appropriately fellow level here.
Looks maybe xanthomatous with some histiocytes in there.
So if it's xanthomatous and there are xanthoma cells, is everything within xanthoma, or what's this debris that's outside?
It looks like there might be some extracellular as well. So you think of eruptive xanthoma?
Well done. I think it would have taken me longer with this one. So there, you definitely. I know. I need a little more time. If you look closer and you see the, quite honestly, I would have thought various things like pecoma, et cetera, at scan. I probably would have picked up on the debris and said, what is that? Okay, are these xanthoma cells? If that's extracellular lipid, then I would have gotten to it. But very good. Well done. So eruptive xanthoma because of the xanthoma cells plus extracellular lipid.
Something definitely deeper. They kind of have the round look of glomus cells.
Damn, you're good. That's exactly what it is. It's the very edge of a glomus.
Not a lot of glomus to go on.
Incredible.
And you see those. That deserves applause. That was very, very well done.
Not much of
Dr. Richard Marshall.
Incredible!
Give me that.
So we have shaved biopsy.
This deserves applause. Well done.
It's like sebaceous skin.
So it's either sebaceous skin or that's part of the pathology.
All right.
What would the surface have looked like?
Sebi. Mammillated
Yeah,
study.
certainly sort of mammillated,
So
right?
maybe sebaceous stuff.
You are right on. Well done. So it's broad, it's bald, it's bumpy, it's bubbly with sebaceous, and it has follicular induction. Neva sebaceous. Well done, Dr. Marshall.
Incredible. He's our big toe.
Needing to witness.
We should
Leave him out the call.
Really good putt. So, kind of starry night pattern a little bit. So, I think it's sclerotic fibroma, perhaps.
So it does kind of resemble a starry night pattern. Are sclerotic fibromas, do they tend to be hypercellular or distinctly hypocellular? And this one is?
More hyper. So this is, I mean, it almost has a herringbone pattern too. I mean,
It
something in
does.
the fibrohistiocytic.
So you might think something fibrohistiocytic. Other things, let's look a little closer at the cells. What's the configuration of the nuclei?
Is this more of a smooth muscle, sort of like wavy?
So is it corkscrew, smooth muscle, long fascicles, or is it short interweaving fascicles with wavy?
The short, wavy.
Okay, which is...
More of a, like the fibromatosis?
Definitely can be. The other thing that...
neurofibroma?
Yeah, neural would be the other thing. And then one of the things you can do is you can look and see there are usually little gray dots in here that are the neurons, if it's neural. So you can pick up, you know, the nuclei are darker, closer
So
to
schwannoma then?
black. So,
Doesn't have
question, schwannomas tend to be deep and encapsulated, but the other thing, this one, it doesn't break up into good fascicles, and it's not vertically oriented, which is why you're not thinking PEN,
Yeah.
but that's what they called it, was palisade encapsulated neuroma. The other thing that can look very much like this is sclerosing perineurioma. If it's S100 positive, it's a PEN. If it is S100 negative and EMA positive, and we don't know if that was done in this case, it's actually sclerosing perineurioma. But you know, a little tougher because you don't have the fascicles there.
Trichomona.
So trichomona is an excellent thought for this.
Crap. Okay.
Well, those are the two things. You are well done. So you see some.
I didn't see the world.
I can't do it.
I'm sorry. Yeah, that was hard.
So there are. You did extraordinarily well. You landed right on what the two possible diagnoses were here. You see a little bit of outer root sheath differentiation with glycogenation, which is why you thought trichomona. And then you have the squamous eddies. You can see that both in IFK and trichomona, both are endophytic lesions. What this is lacking for trichomona is the thick vitreous membrane and the peripheral palisade. So it's better for IFK, inverted follicular keratosis. Well done.
Good work. No, you did that so much quicker. I can't.
And it would not, you know, if I were, I can talk about derm path questions because that's the part of the exam I have nothing to do with. But if I were constructing a question, it would not be fair to put those two as choices.
Oh, okay.
Because there's so much overlap.
It will definitely be a question.
No, I don't think that would be fair to have those two as choices there. Because they both can have squamous eddies, they both have outer root sheath differentiation, they're both endophytic. But you nailed exactly what the differential was there. That was very good.
Warts, right?
Probably neither is wart, but certainly some people like Dr. Ackerman.
Iron said they're warts, right? That's what I was telling
He
you
did,
before.
but there's no evidence that that's true. I mean, in terms of papillomavirus, there are certainly some warts that can look similar, which is really what he was saying.
Okay.
Some follicular warts can look similar, but a true, like a patient with Cowden's, there's no papillomavirus. So, okay.
So you have a ulcerated tumor-looking thing here.
Yeah, and
Lots of blood vessels and hemorrhage.
and if you were to characterize the type of cells composing this ulcerated tumory thing, like the morphology of the cells,
They look like, I'm not sure where.
like long and skinny.
Yeah, long and skinny. I'm worried about angiosarc.
Yeah, so angiosarc with all the blood, and then long and skinny, the other way to handle this would be spindle cell tumor. So, angiosarc, reasonable thought at scan. You might want to put a muscle marker. What else if it's a spindle cell, big ugly spindle cell neoplasm?
Capices.
So KS, given the vascularity. But the vascularity could just be secondary, like tumor vessels. So what other things are big, ugly spindle cell tumors smacked up against the epidermis or eroding the epidermis?
Leiomyosarc.
Yeah, so leiomyosarc, AF, spindled squame, melanoma, and this one proved to be melanoma. Just big, ugly, spindled melanoma. But again, you were thinking your way through it very well.
Superficial of the epidermis. It's a little faded, but I think it looks a little like poromostroma. Oh, it's clear cell, sorry.
Yes, you are correct.
Sorry.
So you said the word, it's a little faded, but only the lesion is faded. One might have said it's a little pale, right? But with a sharp cutoff to where it is not faded or pale. There's always a neutrophilic scale crust and always neutrophils and neutrophilic debris if you look on higher power. But it's a scan diagnosis, that sharp cutoff of the pale area to the normal epidermis. So clear cell acanthoma, well done.
Took a minute of processing.
The way ultimately it hit you and you nailed it like that. Patty Mallarich, one of our residents in Pennsylvania, used to always, warty disc cartoma was her nemesis, and she would always do that aha moment, it's a freaking warty D. And so for graduation, her fellow residents gave her a framed warty disc keratoma for her wall.
Please don't frame me like
Okay.
So this looked like focal lesions, well demarcated. It looks like significant amount of interface.
So there's a lot of interface, right, and lots of dead reds. And then we look at the epidermis. So the question is that primary? Is this primary? What's primary, what's secondary?
Mm-hmm.
When you look at the epidermis, tell me about these nuclei.
They're very atypical.
Yeah, very big and ugly.
Too atypical to be just reactive.
Agree. So this is likely the reactive part. That's just too atypical to be reactive. And then, is all the epidermis atypical, or is it clones of atypical cells embedded in what's left of the epidermis?
Yeah, like kind of a clonal Bowens type of look.
Yeah, exactly. Clonal Bowens with lichenoid inflammation, dense infiltrate. So again, another one not quite straightforward. You have to think your way through it. Well done.
In first impression, it looks nodule in the deep dermis.
Very good.
And then there is some, it looks like maybe this tumor is from Piner or from Sweet.
You certainly have branching and alveolar ducts embedded in a stroma that is pale and in some areas myxoid
myxoid.
So what would give a big round ball of a tumor in the dermis, branching alveolar ducts within a myxoid stroma? Anyone want to jump in?
Mixed tumor.
Cutaneous mixed tumor. So mixed tumor of skin. So the two elements to the mixed tumor are the branching alveolar ducts and the stroma, which can be cartilaginous, and when it's not outright cartilage, it's usually at least myxoid, which means mucin present.
Looks like we got another porome.
Looks like a poroma. That you deserve the easy button for that because you nailed it right at scan. So
That was easy.
so why poroma?
You got these pink cells kind of hanging off the epidermis.
So pink cells hanging off the epidermis. They're about the size of acrosyringeal cells, so they're smaller than epidermal cells, about like the eccrine duct. You have these little circular white spaces, which is duct differentiation, and they never palisade.
I thought you told me they weren't eccrine.
Well, correct.
Okay.
They are probably apocrine differentiation.
Okay. So not sweat.
But they are about the same size of a sweat duct, which is what they were thought to be eccrine because of the. You are correct. Evidence suggests that they're probably apocrine and not actually eccrine in origin or in differentiation. I mean, they probably originate from a pluripotential stem cell. Okay.
I've seen a lot of hair follicles here.
So lots of hair follicles, which could be just anatomic site or could be part of the pathology. If it's anatomic site, where do you have lots of little follicles?
Like on the face.
Yeah, so this is probably head and neck, face, ear, that kind of thing.
Right. There's some inflammation up near the articular dermis.
So there's inflammation, and the inflammation is patchy perivascular and also centered around the hair follicles. And where it's centered around the hair follicle, it kind of follows the hair follicle in a vertical direction.
Talking about lupus.
And then there's a little interface dermatitis and some patulous hyperkeratotic openings to hair follicles. So you are absolutely right, this is lupus. A little tougher than the last one, but you thought it through very well.
So it looks like GA.
Okay, so you get the easy button for that, and why GA?
So you have kind of central necrobiosis for the palisade of histiocytes. Scan, you can see all the multinucleated histiocytes.
Yep. So they're multinucleated cells as a clue that they're histiocytes. And so you have epithelioid cells and multinucleated histiocytes. They're in the dermis, sometimes in a palisaded fashion, and they are certainly patchy and focal, not top to bottom, side to side, which is what NLD would do.
Looks cylindroma spiradenoma-like.
So you are correct. That is cylindroma-like with the jigsaw puzzle pattern, and this is spiradenoma-like with the big blue balls in the dermis. And they're probably variants of the same tumor.
That looks like a PEN.
Looks like a palisaded encapsulated neuroma. So this one, same cells as we had in the last example, but this has the more characteristic clefts. This one, though, again, is a little horizontally oriented, whereas PENs usually are more vertically oriented. When you see something that is neural but horizontal, that's one of the clues to sclerosing perineurioma. In this case, with the clefts, you're correct that PEN is far more likely.
See, epidermis primarily involved. Crusty, atypical cells in there.
Very good.
Is it just an AK or something? Bones?
Yeah, there's certainly a suggestion of clonality where you have some normal
Does it have like
epidermis, and that goes more with Bowen's.
bones? Okay.
But you're absolutely right. You know, Bowen-Erd AK versus Bowen's. I call this Bowen's the degree of anaplastic atypia and the clonality visible within the epidermis. Well done.
Great job.
Fun. It's like riding a bicycle.
You guys don't mind having this fun for me.
Alright, shape biopsy. A little seppi, but let's see.
He's right next to you.
Let's see. I mean, trying to figure out. These are like big dilated hair follicles. So
Yeah, so big dilated hair follicles, and what are all of these cells?
So those cells.
We can go a little higher and look.
I mean, like a pinch-one folliculitis, or
So
those are
that,
newts. Those pachydermal
yeah,
newts.
so there are lots of newts. So newts related to a hair follicle, absolutely folliculitis is
Like a
one thing you'd think of. Newts in the epidermis and corneum, what is your differential?
Okay, so yeah, I guess we're in the P-tics differentials, so like psoriasis, tinea, impetigo, candida, sebderm, syphilis.
Okay, so, and then we're going to look a little.
That's more impetigo. Is that just bacterial colonies? Oh,
Oh,
there's
wow.
Whoa, look at him.
some hyphae, some more tinea.
Yeah, so
Or is it
either
some hyphae,
either tinea or
candida?
candida. And one of the hints here is you can see the swellings where they're really yeast that are germinating with germ tubes. So this was candidiasis. But
Just raging.
That's pretty cool.
but you know, you did very well with the differential. Okay, let's see here.
So, I mean, when I say it looks mostly like it ends in nest. I think mostly Clark's from this height. but-
So melanocytic, well circumscribed, ends in a nest. Some concentric fibrosis, looks very much like a Clark's nevus or dysplastic nevus, whatever you want to call it. You know, this particular one probably originated from hairline in a child. See how small and red the collagen bundles are. So, you know, hairline, and this actually for a hairline nevus or a scalp nevus in a kid is pretty tame. You know, they all look like moderate to bad atypical nevi, even though their behavior is completely benign. So, but well done. Well circumscribed, ends in a nest, nest tips and sides of reedy. That one.
So it looks like you have a cyst here.
Okay, and tell me about the wall of the cyst.
So it looks like there's.
So if you have this kind of stroma around blood vessels,
So like a poroma stroma?
like a poroma stroma, correct? And so, do you know any kind of poroma that's cystic? Yeah, actually solid and cystic poromas, clear cell hydradenomas, nodular hydradenomas, cystic hydradenomas. It's all the same group of tumor that used to be called ecrine acrosporomas, but are probably, now they just call them acrosporoma because they're probably apocrine differentiation. So very good. And that stroma, that poroma stroma around blood vessels, looks almost like osteoid, is a really helpful clue when you see it.
So it's just there's hemorrhage and sternocorium. All Rook is looking a little bit from this height.
Yeah, so definitely this is a papillomatous lesion, right?
A lot of hemosiderin and atypia. So I'd probably call this squame. Are you just showing me that's irritated seb?
So, that's the question. Is it just IFK irritated seb? There's certainly lots of squamosity in here. I don't see a whole lot of atypia. It's pigmented, which sebs certainly can be. So, that's certainly what I favor looking at that portion. And it was called, it's hard to read, but it looks like they called it an IFK. So, with, looks like sebaceous differentiation. I think that's just that it was centered around a follicle. Okay. This one has far too small writing for me to read, so we don't know yet if it's a good one to do or not.
Doesn't look too good.
So, there are a lot of things going on. There's this fibrovascular area here, there's a crust, but then there's also epidermal death and interface here, right?
Yeah, it looks acute.
It does. So, this is probably like an incidental little neurofibroma. That may be the acute change, which again is sort of an EM-TEN type change. This one has enough disorder, you might even think of GVH in it. And let's see if we can read that.
Oh my.
Yeah.
With incidental neurofibroma.
So this area that looks, boy, I'm having trouble saying that those are melanocytes versus necrotic keratinocyte. So this, is sent in by someone. I would stain it. I think that's interface. I don't think that's melanocytic. I see dead reds.
A black patient?
There's a lot of pigment there, but not necessarily a ton in the normal skin. Yeah, but I'm not sure that... all of this looks like interface change. This would be interesting to take back to the lab and put a stain on.
What did it end up
I can't even read. Yeah. See if you can make that out.
7-year-old man with brown macula and central red papule. Pre-op was !PG. And then it says junctional melanocytes unusually S100 negative.
That is
very but Mart, Midif, and Vimentin positive.
So what happens if you get pseudonests?
Yeah.
I think
Central papule.
this may be an old slide before the pseudonests were recognized.
That's a lot of writing for one little slide, by the way.
That is a lot of writing for one little slide. And there is more. Look at this. That's a book on there. So what happens with pseudonests when they were described is you'd have these interface things, and they'd be called MMIS based on the staining pattern. And, it's hard to tell. Is there a date that we can make out on this slide?
Brilliant. Have a March
2009.
But paradoxically, S100 positive, but staining marked. What year?
2009.
2009. So, it was talked about at that point, but not a whole lot. That's probably what it is interface with aberrant staining.
In the first impression, it looks like some cells progressing, and then in the superficial, and there is many neutrophils.
Very good.
Neutral cells, and looks like vaniculated, some eosinophils, and
Very good. So you have blood vessels filled with neutrophils. Some of them start to traverse outside, joined by eosinophils, but there is no karyorectic debris. Very good. So urticaria. So urticaria starts with vessels packed with neutrophils. The neutrophils work their way out, joined by eos, but no nuclear debris, no karyorexis. If there is no leukocytoclasis, there's no LCV. Right.
Looks like I infiltrate down into the fat.
Yeah.
Looks
This is another one with lots of writing, so we're going to have to work our way through it. Right?
Looks more septal. I mean, the lobules are preserved.
And there's certainly a lot of necrosis here, right? So neutrophils, necrosis in the fat.
So like tuberculosis, infection.
Yeah, exactly. So infection's probably top of your list.
Alpha-1
And then
antitrypsin.
alpha-1 antitrypsin, excellent. So infection and alpha-1 antitrypsin, so you'd stain it, look carefully for organisms. Calciphylaxis can be subtle, and sometimes you have the secondary neutrophilic infiltrate, but I don't see a lot of thrombi. Let's see if we can make out what history is here. So the patient has a history of lupus, vasculitis, thrombosis, necrotic ulcers. Okay, there you go. So, reason for any of those things. You got as far as the differential, which is good.
So like a lot of pink strands, it looks like.
Pink strands, and at the end of those pink strands,
Blue.
so anastomose and pink strands, blue buds.
Pinkish.
A pincus tumor. Well done, sir. You get to hit the easy button.
Oh, yes, I
Hit
did.
it, Caleb.
That was easy.
Oh, yeah.
Usually abut the epidermis.
I'm sorry?
They usually abut the epidermis.
Yeah, they usually come down from the epidermis in strands.
That seems sort of deep and weird.
How does pincus differentiate from infundibular cystic?
So
BCC?
pincus are anastomosic strands that trap connective tissue. Infundibular are fingers that radiate out and never encircle connective tissue.
Gotcha.
Let's see. This is another one with lots of writing on the side.
I mean, my first thought at scan was a PG.
So first thought at scan, PG, I think is an excellent thought. That's a little hobnail-y, maybe, those vessels.
I'm not seeing ears.
I'm not seeing EOs, but, and they're not big histiocytoid, but, one of the AVM variants, and a PG is an AVM.
It has really good color.
It does. So I agree with you. Let's see what they say. They called it an AVM, but a PG is a form of AVM too. So you get a little needle stick, you get a little traumatic AVM, and you grow a PG. So I think you're right. It's benign vascular in response to trauma, and I think we're out of time. Time flies when you're having fun.